Hi, everyone. I am so excited to introduce Heidi Waldorf, who is the most amazing dermatologist that I had the pleasure of meeting in 2016 at IMCAS. And I remember Heidi coming up to me and just chat, 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 chat. And I could not get over her infective energy. It was amazing. I shouldn't use the word infective.
I was thinking it's a good word though. It is.
It's a
That's a
great
good
word.
kind of infection.
And then I follow Heidi on Instagram. And if you don't follow Heidi on Instagram, you are missing a trick. She is awesome. I don't know where she gets the time to post the kind of stuff she does. And what I particularly love is her driving in her car and talking into her camera, which currently she's not doing because obviously
Right.
she's in lockdown in New York. But Heidi is awesome. And I wanted to have a little chinwag with Heidi about filler freakdom, the filler face, because so many patients come and see us petrified of how they're going to look. And this is also for aesthetic practitioners. So this is to talk to aesthetic practitioners to sort of tell them what is it, why it occurs, what can we do to prevent it. So Heidi, I see quite a bit of filler freakdom. Okay, but I want to ask you, what is the difference between a filler face and filler fatigue? Because there was a lot of talk in the media last year about filler fatigue, and I can't find any scientific publications on it.
No, and I think first, thank you for having me and saying back at you about, I love your posts and all the educational stuff you do. And hopefully when this is all over and we can travel again, I would love to come out and participate in one of your
Oh,
sessions. They look
awesome.
so amazing.
Ofa would love that.
It would be fantastic. Now, I think one of the baselines that is that the aesthetic, your aesthetic and the aesthetic of most of our patients uh, of the patients in your area are very similar to mine. They want that look of looking like they didn't try so hard, like they just woke up like this and they're afraid of looking like a filler freak. They're afraid of looking unnatural, but at the same time, they want to look better and different. And if they are not led correctly, they can end up in this sort of overstuffed filler face or overdone filler freak look. And I think it's our job as injectors, as aesthetic leaders, to lead our patients. I do a video editorial for a journal, Modern Aesthetics, and called Ideas for Aesthetic Practice. And at one point I did The Power of No. You know, there's a book, The Power of Now. Well, the power of no is learning to say no to patients, because one of the ways that people end up with that filler face, that overstuffed filler face, is that in trying to fix what the patient dislikes, the person continues to add and add and add. And as we know, doing the same thing is not the way to fix a problem. You have to take a step back. I liken it to surgically, you know, in the old days, I used to be a Mohs surgeon over a decade ago. And if you have a dog ear that goes on forever, you know, a little Burroughs triangle,
Yeah,
you didn't set it up quite right. You can still
exactly.
fix it, but the plan should be that it shouldn't be something that's going to go on and on and on. And we shouldn't have to chase it out. It's a dog chasing their tail. The thing with filler face, which we just discussed, the overstuffing versus filler fatigue, I agree with you that I think filler fatigue is a made up word. The face does not get used to filler. The filler does not stop working unless you're talking about something that's purely biostimulatory and someone just ages and it's not going to do anything.
Exactly.
And that's different. What I see is I will go in and a patient will say, it's not doing it anymore. And one of the first things I'll do is I'll look at them. And then I look at they're sitting upright and I look at the body and I look and I'll go, did you lose weight? Because many times they'll go, oh, well, you know, I'm not really trying to, but I gave up gluten and I gave up sugar and I'm not drinking alcohol and blah, blah, blah. Oh, and I got a Peloton. So you're like, and they may say, well, I only lost 3 pounds, but they're 5'3".
Yeah. Yeah.
and 3 pounds, and it's a huge difference. And so I try to explain to them, if you've taken away the natural stuffing, then anything I put on there isn't going to look as significant as it did before. So that's one issue. Another issue that comes up is age. So someone will come back and go, well, in the past, I could come here once a year and it was great and we did it. And
Mm-hmm.
then I look and I'm like, but you're 5 years older now. And do you remember last time I spoke to you, I suggested you might want to come back in a month for more filler, and rather than waiting a year, or at least 3 to 4 months. And do you remember we talked about tightening procedures? And do you remember that I was mentioning that I think you're nearing a blepharoplasty? Because
Mm-hmm.
often the number one thing I send people out for is upper lid blephs,
Mm-hmm.
because that's genetics and there's a limit to what we can do. We can put things off. And often when I meet someone, even if they're in their 30s, I'll look and I'll go, just putting this out there, you're not there yet, but
Mm-hmm.
at some point we're going to keep an eye on your upper lids,
Mm-hmm.
because that's genetic. And I show them, you can't see it here, but my eyes, I'm more of an A deformity person.
Mm-hmm.
I
Yeah.
don't have deep set eyes. So every now and again, I need filler there. We do my thermage there for tightening. It's less noticeable with with the glasses
Mm-hmm.
there, but I have an A deformity. But for me, the issue's always been a tear trough. For these other patients, often it's the upper lid.
Yeah.
And it's the same ones who say, my tox isn't working. Well, guess what? The
Exactly.
tox isn't going to work because that's a fold of skin. And I like to discuss things in ways I think the patient can understand. I mean, I joke, it goes back to college. My college roommate and I were both economics majors. I did public health, and uh, we had a core curriculum. So when I got to international, the little E, the macroeconomics, she had to help me. And when she had to take her core science, I remember teaching her bonds, like electronic bonds, talking about peanut butter and jelly,
Mm-hmm.
US, a classic, how things stick together. And that's what we go down to with the patients. And I think if you talk to them as though about building, because so many people, at least in the suburbs, they've done some building project, they know what it takes to make a house. And you say, look, we've lost the struts. It's as though the struts of your house have gone down, and that's what we have to lift. And we talk about the jawline. We talk about, when you start asking them questions about osteopenia, you start asking them questions about their teeth. Look at their teeth. I
Mm-hmm.
mean, these are veneers. These are
Yeah.
very well done veneers.
Yeah.
And having the veneers, which I did for issues of gum recession, frankly, held up my central face where
Mm-hmm.
I'm narrowest.
Exactly.
And I think that's why these things all fit together. So if we discuss it with our patients, we can then say, is this really that filler's not working? And you know what? You got it. It's time to go have surgery, or it's
Mm-hmm.
time, as we discussed, to do more things here.
Energy-based devices, things that are
Exactly.
not just rely on
Exactly.
filler.
Right. And that's the thing. The other analogy I like to share with people, because patients will go, well, should I do this or this? I say it's like an outfit. It if you have an event, you're not just buying the shirt. Is it the
Exactly.
top, the belt, the skirt, the Spanx? You need some earrings. Maybe you need some different a purse. Even for guys, let's be real. The cummerbund, are they having a different
Mhm.
tie? They have the little cufflinks. So we have to describe it to them and tell them it's a full picture. And that's where I hope that it is where I first separate what's going on.
Yeah, that's a good point, because remember, I mean, for me, I realized that if I educate my patients, then they come in because I'm talking to them. They've already understood what's happening anatomically. They've understood that we're going to use combination techniques so that they look natural. But sometimes I will have a patient who comes in who doesn't, who looks really overdone. So they're
Oh
not my
yeah.
regular patient. They come in and I get a shock. And my staff get a shock. And I'm trying to put a paper bag over their head so that nobody sees them in the waiting room and judges me and thinks this is my signature treatment. The, Heidi, how do you approach this? Because this is really difficult. When I was much younger, and I am still a people pleaser, I found it really hard to tell my patients no, because I was trying to navigate it, and I would say things like, this treatment's not going to match your expectation. I was very softly, and of course that has changed as I've got more experience and I've got more confident. But I see that with the younger novice injectors, they tend to do, oh, I want 1 mil here, or I want this, and they're not able to bring it together. So what would your advice be when you're talking to these patients?
I completely agree with you. And I think this is something that everybody faces at some point. Now, those who know me are not surprised that I'm rather straightforward at all times, for good or bad. I spoke at 6 months in full sentences. It's that kind of thing. Um, it is a fine line, because especially in this day and age of people writing reviews, you don't want, you and I may be less worried about that because that's not our core patients, but the people starting out, that's how they're going to get their name initially. And so just be aware that not everyone is going to respond well, even if you do things the right way. When I have a patient come in who has a list first of every place they've been treated and by everyone, and I always ask specifically, I ask my nurses to write down, if the patient hasn't, who did those treatments, because it will also let me know, were they seeing good people and they just were not following the rules? Were they just bouncing around? The people in the US, I don't know, do you have Groupon and those, like the people who
Yes,
every day see
lots
someone
of it.
else? And on that note, I will also say that I have discharged a patient for bouncing around, because I said, I can't do for you if every time you come in, we talk about it, you leave, and then you have things done elsewhere. And then I have to, I erase it, and I can't do that. And so that was a reason. I have lots of patients though who I share with doctors, like half the year in one state or one country, half the year another, and that's very reasonable. I try to explain to patients, if they're bouncing around, they're going to look like a Picasso. Even some of our colleagues have that because they want to get treatment by whoever is teaching a session.
Exactly.
Don't do it, because even if they're fabulous, there are 5 people on the planet who have injected me. And usually it's different years. It's who is in town when I have time. And these are the people who know my face, just like we get to know the patient's faces. So over time, we know what works best, what doesn't, and you have the overall aesthetic. Now, what do you do when someone comes in and it's a problem? So an example, a patient came in last fall, and very pretty heart-shaped face, but overstuffed. And what bothered her was she saw a dimpling here. She felt like there was a lot of emphasis here. But when I looked at her face, her cheeks started at the lid margin. They had effaced the margin between the nose and the cheek. There was no clear definition. There was no sign of a nasolabial fold, but she had thickening on the sides. And she had gone back to the doctor and back, and the doctor kept chasing things out. So it's funny, my nurses say to me, they notice when there's things that I do, when either I'm trying to get an explanation across to the patient. I never realized this, but apparently I take my glasses off and go, and I play a doctor on TV thing, but I realized it's almost as though I feel like I need to take one extra barrier away that they're going to look into my eyes. But the way I approached it, for example, with this woman, I said, I started by saying, we all have different aesthetics and we all evaluate a face differently. I say, you have beautiful features. I said, if I use my good friend Ava Shambam's term, signature feature, I said, your signature feature are your eyes, but they've been downplayed here. You don't look at them because all I see are cheeks. And I said, I don't want you to walk out of here feeling badly about yourself. I'm telling you what I see. And what I see is that we need to take down. We need to take away rather than add. And then you wait. So you wait. And then you see what happens. Now, some people are like, but won't you add anything now? No, because I'm going to dissolve filler. And I'm going to tell you that while I anticipate you're going to need more dissolving the next time you come in, you need to know that some shallow hollows and some grooves and some folds may seem to reappear. Don't freak out. Some of them need to be there, and some of them we will fix in a different way. Now, some of those are some of my favorite results, because the patient's just so beyond thrilled and happy. They had no idea this could be done.
Yes.
People have just been adding and adding and adding, and they are very grateful and wonderful patients. But then you also get the people who are not happy with this. They are dysmorphic, and they are looking at themselves in a specific area. And all the education on the planet won't do it. We try to explain. I even have from a New York Magazine article, 20 years ago, where they talked about the new face and the old new face. The new face were the Michelle Pfeiffers and at that time Naomi Campbell, not so much now, but the women who looked like themselves, but beautiful, but ageless. And then you had the women, although I adore Cher, we know she has gone through some phases where she does not look like herself. The people who, when you look, all you see is that they've had procedures.
Yeah, exactly.
And so I say, we want to keep you in this category. Now, I'm 55 years old. I'm basically hormonally older than that, because at 43, I had breast cancer. So chemo pause at that point. So I've had like no estrogen since then. But I can still look like this. And I think it's important for the patients to know what our aesthetic is. Now, they're not going to be able to see us looking like this up close, at least for the near future, because we'll be wearing masks and such. But I think it's important that we have access for them to how we look other ways, whether it's on your website, whether it's talking on Instagram. And we should show ourselves not just airbrushed. Exactly. Because they should see. I mean, you can see when I smile, I'm asymmetric. Of course I'm asymmetric. We're all asymmetric.
I'm asymmetric too.
Right. I point that out to patients. I will say, just be prepared. I had one patient who I was telling her, look, I showed her the before pictures. I said, look, you're asymmetric there. And she said, really? I said, look at how I smile. And I smiled. And she said, you smile like that? Crack up in the office. I'm like, yes, I do. Thank you. So just be prepared for people say the wildest things. But also, this is a time when you can try to weed out the dysmorphic ones. Yes. The ones who have a deeply serious issue. Because it's normal not to see yourself exactly, but that extreme is a problem.
So one of the things we're going to share some tips, because I'm aware of the time. Yes. One of the things I've learned is actually asking them for photographs. So I asked them for photographs, to bring in photographs from a time when they were happy with how they looked. And when they come in, we photograph them. So before they even see me, they filled in a form with my staff, and they have written down all the treatments they have. And invariably, they haven't covered all the treatments they have. Right, exactly. Because they'll only put in like, a fourth of the treatments they've actually had. They gloss over it. They like to think in their heads, that they've not had all these treatments. Then they get photographed, and they get photographed frontal, 3/4, side profile. Right. That gets uploaded, and they come into my room. And they also have the photograph of when they were younger. And then I ask them what their issues are. And this, I find, for me, helps get the conversation away from their Instagram appearance or this bubble they've got in their head of what they want to look like, this filtered look. And some patients will actually put in filtered images of themselves. So they'll send me an image, or the image that we're consulting with of what they want to look like is there are no pores. They're completely airbrushed, completely filtered look. So that their aesthetic is, is different, that they're going to need a reality check. And I think that when I do the consult with them with that, and we discuss the volumes they had in youth, the volume they have now, they start becoming a little more receptive to the idea of, how we're going to restore. Because with filler Freakdom, you really need to start taking it down. And they're so afraid of losing the volume in their face that they're living in a bubble where they think it's normal. And in fact, their friend circle think it's normal. So they, often their social bubble is completely different. So they don't think, or their friends are too scared to tell them that they look abnormal. So it comes as quite a shock when they see it. I am very empathetic, and
Yes, and I think that's critical.
and then again, like you, I let them stew on it. And I always request that they go and get a second opinion.
Well, and for me, we will do the treatments immediately if they are attuned. That's how I like to work. I know, like you, so many of my colleagues have them bring photos in. My problem is every time they bring a photo in, it's from a wedding. The lighting's good, everything's perfect. So I focus more on what I see, but again, you have to know your population. And for me, having the photos is key. Certain things are going to change. I'm used to looking directly at the face and having them hold a mirror. I'm going to be working more with the photos, pointing things out on the photos now. I focus structurally, and another clue, or I would say a little hint in terms of how to deal with someone who is afraid to take anything away. I have had the people who are so boggy here and everything's folded over. And what I will do is say, okay, before we take this down, let's work on blending.
Mm-hmm.
And then, so what you can do is I might treat the piriform, because remember, if I lift the middle, it can help the transitions. And if it's one of those people who, when you look from the side, the entire face starts here, forward, I will start blending the jawline. I'll start blending the cheekbones, because if you can create that along the zygoma, that I talked about, that reflective C that people, the makeup artists see. And I did an Instagram live with one of my my nurses about makeup, where she was doing her contouring and highlighting and explaining how it actually helped her understand what we do. And that way, if I'm doing that, then when they come back and they're already go, oh yeah, no, I don't understand why. I don't know why I wanted more here, but you put it there, but it looks better. It can start building that trust that then they can allow you to move them in the right direction.
Exactly.
So that's another hint on how to deal with them.
Perfect. I'm going to ask you, where do you think for a practitioner the issue is? If we say, okay, it's the aesthetics, novice practitioners get it wrong because they tend to follow, algorithms, and they tend to use the product, they interchange different products thinking the rheology is the same. What they don't understand is the filler not only lifts, but it also spreads out, and that can happen over a couple of weeks. And so if you have injected a lot in the anterior cheek in an attempt to lift it, it's going to look different when the patient comes back. What is the one thing you think that you have changed in the way you treat patients to avoid this filler face appearance?
Well, I wouldn't say so much that I have changed, but something that I feel is critical, especially when you're starting, is to make that follow-up appointment for the patient on their way out. Because whether it's surgery or injectables, you want to see your results. The people who say everything they've done is a home run have never seen those patients back.
Exactly.
There are times, even let's say someone doesn't make that appointment, and then 4 months later, they go, well, I'm thinking of coming in, but I don't, like the staff will call them say it's time to come back. And they go, well, I wasn't really happy. Oh, but you didn't keep that appointment. When they come back and we review it, they were not aligned with the plan. And so the goal is to make sure they're aligned. Now, sometimes, like for example, a toxin procedure, I had a patient who truly, I was like, you know what, maybe it didn't do what both of our goals were. So now we're going to do it, but you're going to come back at the 2 weeks. And I think, don't be afraid to have people come back. Tell them it's a blessing visit. That's what I do. Unless we do something more, it's a blessing, because you want to get those photos. You want to see what works and what doesn't. And I think that is key, whether it's surgery, whether it's, you know, I had a Mohs surgeon when I stopped doing Mohs who used to come into the office back when we had that in the office, and she didn't want to see any of her follow-ups. And I thought, how can you
Yeah.
never see your follow-ups? So I think that's key no matter how far along. Once the patient's been in your practice for a while, they don't have to come back every 2 weeks, every 3 weeks. But I think that's important in terms of dealing with that. I also would say, don't focus on, as you said, the algorithms.
Mm-hmm.
You know, there's that Picasso quote about, to paraphrase, basically you start off learning the rules and it's the same painting, baking, everything. And then the artistry is when you can change them. So we
Exactly.
learn the rules so that we can know and understand the science. And then the creativity comes with playing it. And it all depends when you're seeing the patient. You have to look from the front, look from the side as you're doing, which sounds so obvious, but people don't do it. And don't worry, oh, I put 0.1 here, so I'm going to put 0.1
Mm-hmm.
there. We're not symmetric. Also, a slight difference in angle on one side or the other, because we're not machines, you
Yes,
may need a little more to get that effect on another
exactly.
side.
So
So
I agree
pace
with you.
yourself.
Follow up is really important. I always tell them, I always leave the door open when I'm treating them. And I say, look, if you have any concerns, anything that you're worried about, that you think, you're not
Yep.
happy about, or you're just concerned, just email us. So they have an emergency mobile number,
Yes.
clinic mobile number. They have an email that they can send us pictures. We encourage them to send us pictures so that we know what they're talking about. We also sometimes
And we tell them also, we need to see it at the time, because describing it to me 3 months later doesn't help.
doesn't help. And then I always tell them with fillers that I like doing progressive treatments.
Same.
That this is not a one-hit wonder. It's not a home run. I need to. It's like it's like art. I'm putting these little brush strokes on,
Yes. Or
and
tailoring.
exactly, and I'm giving
Tailoring. I
them a
mean, you don't
timeline.
have one fitting in a dress.
Exactly,
You know,
exactly,
you need
exactly,
that second fitting.
exactly. So, Heidi, I think we've shared some great tips on
That's
how we
great.
can recognize filler freakdom, how we can try and manage, the overfilled filler face. Is there anything else you want to say, to the OFA subscribers before we sign off?
I would just say, trust yourself, trust your aesthetic, and learn, learn, learn. Look at every face you see. Listen to the people who are talking anatomy, who are talking aesthetics, who are talking, this is what we do. And we're only going to keep getting better at it as we absorb and take pearls from other people. So I think this is great. I think an education like this, just getting, if you can get one pearl,
Exactly.
you'll
So,
treat everyone better.
exactly. So I'm going to end off with just 2 tips. And the 2 tips are: check your patient dynamically. So the biggest important thing is the smile. I have an asymmetric face. One side of my face is smaller than the other. So my muscles move differently. And what I do is, when I photograph the patients, you can actually see these asymmetries in photographically much more, but then I make them smile and they see the muscle pull is
Yes.
different. I have a different muscle pull. I actually had a fracture last year and I have a metal plate in my zygoma.
Oh,
So, that's caused and it was my thinner side of the face. So now that side of the face has got even thinner because of soft tissue atrophy. But, because I understand that, but it's the translation to the patient. So you want to have these images, particularly images of them smiling, because sometimes when they've had the filler in, they'll come back at 4 or 6 weeks and they'll tell you, I'm too big, because they start looking at this. And actually, when you've got proper imagery, they see that it's not looking that big. So I would say to you that one of the top tips is, make sure that you are assessing your patients, photographing your patients dynamically in addition to static images, and embrace progressive treatments, because then that's the only way you are going to try and minimize developing the filler face. Because certainly I was there, as a novice injector many years ago. When you're learning the art, you're learning about the rheology. You don't know how it's going to spread, you don't know how it's going to look, you're a bit enthusiastic, So we've all been there, and developing a reflective practice and learning from your own mistakes is very important, rather than learning from other people's mistakes.
And also to say, I totally agree with both of those points. And I would add to that, don't be afraid if you have to tweak. If you have to say to someone, you know what? Yeah, I don't love it there. I'm going to grab some hyaluronidase, and we're going to tailor it a bit.
Yeah.
Just tailor it. Everyone understands that.
Yeah.
And it is what it is. And for the record, if someone comes from someone else, I charge for that. But if they're my patient, I put it in, I'll take it down.
Free.
And
I do
think
the
that's
same.
for free. Yeah. Because you know
Yeah.
what? It's part of the whole design.
Exactly.
So,
exactly.
and it's not that you did anything bad. You're just, I want it to look a little better. I want it a tweak.
Yeah. And I find most patients, when they understand the journey, are very understanding and forgiving of that.
They're thrilled because they look better.
Exactly.
They're like, oh, I didn't know that's the problem. I thought I needed more next to it.
Exactly. Right. So that's our time up. Heidi, thank you so much. It's been fabulous.
Thank you.
I hope New York gets out of this. I hope all of us get out of this.
And London, everywhere. Yes.
And when we're all back at work, we'll be meeting in person. And I look forward to seeing you at the next Congress, and hopefully
definitely
training with us at OFA.
I'd love that. Sending virtual hugs. Hugs.
Virtual kisses.
Mwah, mwah, mwah.
Bye.
Bye. Stay safe. Bye. Thanks.
I'm just, hang on a minute.